My name is Milos Dimitrievich, and I am from the team MADUP, from the company MADUP. I am one of the co-founder, and the idea was for us to be able to give you all the right knowledge and to have all the tools to be able to apply blood flow restriction in a safe and optimized way. So this is for tonight our goal, our idea. I will give the word to Mr. Papakostas, who will be leading the live tonight, and he will present all the participants.
Hello from my side. Being also in Greece, but being the connection between Greece and Qatar. So we are here in this live event, starting a little bit late, but as Milos stated, most probably you're going to be compensated for your patience and for being here, staying with us, and sharing knowledge and exchanging ideas down the line. So I'm an orthopedic surgeon. I hope that you can see my screen from now, so you can just one of the administrators can say yes, okay, or can give me a thumb up if the screen is okay. Thank you, Vas. Thank you, Guy. So I will give you a small presentation regarding the blood flow restriction protocols, how safe it is, and the application. And I will also give you my small experience in a post anterior cruciate ligament reconstruction situation. And I will later leave the floor to two exceptional physical therapists, Stefanos Karanassos and Vasilis Korakakis. One is established in Athens and the other one is now established for many years now in Doha. So they will have a vast experience in blood flow restriction protocols. The first one, Stefanos, is dealing with upper limb mostly, and especially with lateral tendinopathy, elbow tendinopathy. And Vasilis is also a kind of an expert to a lower limb and especially anterior knee pain. And he will give you, they will give you their insight and definitely some more information regarding the rationale behind blood flow restriction protocols. Most probably, you will face in the next hour. You will face some plagiarism. You're going to see the same, in some cases, the same even ideas in slides. But this is down the line the most important thing for us to duplicate, let's say, and to give you some feedback. I will try to give you some information, some general information, but I guess both Stefanos and Vasilis will also give you kind of the same information, but more focused in special issues. At the end of our presentations, you will have the floor, and Guy, the other co-founder of MADUP, will give us an abstract of your questions. So we will have some, let's say, 10-15 minutes to answer up your questions regarding this technology. And we will try to be as general as possible, but we also have to go a little bit deeper inside. Although I don't have any disclosure regarding this today's communication and lecture, I don't have any certain commitment with MADUP, but I really appreciate their technology and the rationale behind it. So just to give you a historical background, most probably all of you know certain things regarding blood flow restriction and how this started. It started back in 1966 with Dr. Yoshiaki Sato, who the history behind it is that he realized that after being praying in a highly flexed position, he realized, like a Buddha monk, he realized that he had some positive effect in his muscle, in the muscle hypertrophy of his of the lower limbs, and this gave him the push to start looking deeper a little bit in this protocol, the blood flow moderation, and he realized that by modifying the blood circulation in the limbs, maybe this will help to build the muscles through most probably a biochemical reaction in the brain. And this was the beginning, which was started like most probably some of you know, the Kaatsu training regimen and protocol, which is initially, we can say that this was the birth of a blood flow restriction, and with many implications and many implementations after that later on. So the definition is that by using a cuff, an inflatable cuff or tourniquet to the limb, proximal to the muscle that needs to be trained, the result is several muscular strength gains and hypertrophy, and this is supported by literature starting from 2010 up until now, and I will give you some small overview later on. The idea and the main physiological mechanism behind it is that by reducing the oxygen input in the muscle, this reduction of the oxygen in the muscle promotes the capillary filling, and this goes into muscle fatigue, but without major muscle damage and major muscle trauma. This gives something like a signal to the nerve system to transfer the message to the brain that the muscle needs to be helped. And this has a result of increasing the secretion of growth hormones from the pituitary gland, especially the growth hormone. Anabolic hormones secreted from the pituitary gland is released in the periphery, and this facilitates the repair and increases the strength, having as a major result the muscle hypertrophy and by thus increased muscle power. We definitely know that high intensity resistant training and resistant training in general, either high intensity or moderate intensity, in some cases low intensity as well, has several effects on the muscle by primary and secondary mechanisms, which we call the physiological mechanisms. But we do know that high intensity resistant training has this effect on the muscle by implementing mechanical tension in the muscle and not that much metabolic stress, which is also one pathway, but it's not the major one. On the other hand, it is proven by several papers that were published in the last years, mostly in the last 10 years, that low intensity resistant training with blood flow restriction has similar, or in some cases even better result in the muscle hypertrophy and muscle strength by the pathway of metabolic stress and not by the pathway of mechanical tension. In parallel, several secondary mechanisms which are more or less common, like fiber recruitment, systemic and localized hormones, and all the things that you can see in the middle of the slide, play a role in both situations, in high intensity resistant training, but also in low intensity resistant training with the BFR. But in the first case, mechanotransduction and muscle damage is the secondary mechanism, which is the major one in this situation, while in low intensity resistant training with BFR, the cell swelling is the secondary mechanism that leads to muscle hypertrophy. So all these mechanisms lead to adaptations to blood flow restriction, which is hypertrophy, strength, muscle strength gain, endurance, remote adaptations, running economy improvement, and sports performance improvement by all of this. And Vasilis will give you some of his work later on today in his lecture. And we definitely also know that when you start searching into literature and to see what are the major areas of research regarding blood flow restriction, you can see that patellofemoral pain, muscular hypertrophy, and strength gain, it is used in knee arthroscopy rehabilitation, in osteoarthritis, either prevention or reducing the risk, in postoperative muscular inhibition, endurance, and all these wonderful things that you can see here in the slide. Just to give you also a clue, I understand that this communication today and these 3 lectures will be uploaded in the MADAP Facebook page, and you can have access whenever you want in order to come back into some idea. Coming to safety, it is regarded to be a very safe at-office procedure, and this is quite established. The safety, there are not major safety issues if you follow up the contraindications that you need to avoid, of course. And although some cases of venous thrombosis or even syncope and rhabdomyolysis and skin bruising from the use of tourniquet and inflatable tourniquet are reported, but these are not in the area of not considering this technique as a safe in-office procedure. Coming into the contraindications, there are definitely several parameters that need to be taken into account, like you don't use BFR techniques in cardiovascular disease patients, and whenever you have a recent musculoskeletal injury like an open fracture or a major infection, of course, pregnancy or uncontrolled metabolic disease like diabetes mellitus, and whenever there is a family history, especially with thromboembolic episodes or special drug and medication like hormonal medication intake or contraceptives and anticoagulants, these are the contraindications for someone not to work with our patients and with our athletes with this kind of technology. Last night, I just put in PubMed these keywords: blood flow restriction training, and you can find that there are 446 articles published in total. I think the first publication was something around 1980, and but in the last 10 years, 605. In the last 5 years, 456, and only in the last year, I mean, from July 2019 to in 19 to 20, 147. You can see how much the scientific community is moving into this line of field, but we are facing several problems that my 2 colleagues will give you some overview later on. The good thing about this kind of technology, the low intensity blood flow restriction protocols, is that you can sum up all the good things and what is going on in this table, which is adapted from the MADAP website. And when you deal with high intensity training, you need to work with 65 to 90% of 1 repetition maximum, while in BFR protocols, you work only with 10 to 30% 1 repetition maximum, which is, as you all know, a very low intensity. So the muscle damage, which is measured by CK enzyme, it's not significant. The lactate production is present as in high intensity training. Activation of type 2 muscle fibers is almost common, like in these 2 situations, while growth hormone increase is 100-fold increase in high intensity training, while in low intensity BFR is even far more, which is most probably the mechanism, the physiological mechanism behind the major effects of blood flow restriction protocols. And you can see the major difference in the last line of this table, which is, in my opinion, the most important one because of the previous ones. It's a quite safe, without causing muscle damage, having a greater increase in growth hormone, but it's only a faster process, as you can see the same results and very good results in only 2 weeks compared to 12 weeks high intensity training. So it is quite safe to be used in earlier stages. There are several very well established publications, and I guess that my colleagues will give you some insight later from this as well. So you can use it definitely after knee arthroscopy. You can use it in each way that you want to use it. It is used also, of course, and published in osteoarthritis prevention, and there are more protocols and more research coming up from that side as well as we speak. It is used in patellofemoral pain, but I don't manage to get all the data around, because our two experts will give you more clues about this. And it's also used and published in case studies and case series, but as in case reports as well, which is one of the problems that we are facing, and I will come to this later on, in the persistent postoperative muscular weakness. One of the most important ways to deal with this is following up this Lönneke's progressive model, in which it is described that you can divide, let's say, the implementation of blood flow restriction protocols in 4 phases. You can use it during the periods of bed rest to avoid muscle hypertrophy. You can use it in phase 2 with low workload walking exercise, with low load resistant exercise, but also in phase 4 in combination with high load exercise. And this is something that I will present it later on. In my opinion, in my experience working with ACL reconstructed patients, it can be used definitely in prehab, as in the passive mode, which is one of the major advantages that MADAP offers to the community, and in low intensity BFR as well. And in phase 1, as in the recovery from surgery, even after day 2 or 3 or even 5, after you can use the passive mode until swelling subsides completely, and you can use low intensity BFR with MADAP in a closed kinetic exercises way. And you can also use it in later stages, in the upcoming stage of strength and neuromuscular control, which is in a way that you use it in closed kinetic and open kinetic exercises as you choose in low intensity protocols. The most recent systematic review of what is published around in the ACL reconstruction area regarding blood flow restriction was published some months ago in the Orthopaedic Journal of Sports Medicine by a very good group from Chicago, and they stated that they concluded that there is a potential muscle strength and hypertrophy benefits in patients undergoing perioperative BFR, but the limitations, of course, are that we don't have standardized outcomes, and we don't have long-term follow-up, and we definitely need more patients in order to see. But this comes to the final part of our conversation from our side, at least, that we are dealing with these kind of problems with the MADAP Pro, having its advantages of having a personalized pressure and monitored pressure, real-time pressure regulation, and a timer, automatic inflate and deflate, automatic and manual pause. And this can give us the benefit of having a standardized and reproducible situation by having standardized protocols, a calibration all the time, and coaching as well, which is very important, with countdown metronomes and pressure adaptation and indication. So as a conclusion, I think that BFR in general is a very safe procedure as long as we follow up the indications. We definitely can use low intensity training in order to have our results, and this goes into quite high muscle gains. There is a pain reduction module that most probably Vasilis will give us some clues as well. And there is also a faster return to leg symmetry, which in my opinion is a way to return faster into activity, sports, daily living, and even competition. Down the line needs to be reproducible and standardized, and by this way the efficacy will be scientifically supported as I believe it and I perceive it. I take the opportunity, of course, to thank my family, my co-workers, and my the whole group, the orthopedic group team in Aspetar. So thank you very much. And now I need to give the floor to Mr. Stefanos Karanassos. We have some common grounds in terms of he studied physical therapy in Thessaloniki. So he's a physiotherapist who's working as a senior musculoskeletal physical therapist in a private clinic now, in a private setting in Athens, in Kifisia. So he used to be a very high skillful student, but he developed also in a very good way, in his professional way down the line as a physical therapist. He completed two masters. He deals with, especially in UK, he deals with upper limb, and he's now in the way of finishing his PhD in lateral tendinopathy, if I say it right, and especially with a BFR technique and protocols. So I give the floor to Stefanos Karanassos, and we'll be in touch later on.
Thank you. Thank you for your kind words. I hope you can see me, and I'm going to share my screen. And is this okay from the administrators? Okay. So initially, I would like to thank the organizers of this great event, this interesting meeting. I feel that I have to congratulate this team from MADAP for their excellent work in the field of this of the development of new technology in sports rehabilitation. They are very supportive, and of course I have to express my deep feelings. I feel very honored being part of this team, of this small group of speakers between one of the best orthopedic surgeons in Greece and sport medical doctors, and Mr. Papakostas, and of course the most famous Greek physiotherapist and researcher, my friend Vasilios Korakakis. As far as myself, I don't want to say, Mr. Papakostas said a lot of things about me, and I regard myself firstly to be a clinician, and secondly to be a clinical educator and an active researcher. As far as my experience with blood flow restriction, I have started dealing with the method for the last 3.5 years, when this movement became more and more popular in Greece. For the last 2 years, under the supervision of my professor Georgios Giovtsos in the University of West Attica, the physiotherapy department, we are studying the use of blood flow restriction training in upper limb extremity tendinopathies, with main focus in lateral elbow tendinopathy, which is a very common term called tennis elbow or lateral epicondylitis. So in this perspective, I will describe my point of view, my clinical experience, and some part of our research data regarding our experiments. I have to express my, I have to be sorry for some aspects of my presentations that are overlapping what Mr. Papakostas described previously. However, I will try to be more focused and to discuss one step further of the things that Mr. Papakostas underlined. So again, of course, the developer, Dr. Yoshiaki Seto from Japan, he introduced the term katsu training, which means training with added pressure. Nowadays, we have developed these techniques in more sophisticated pneumatic tourniquet systems, which are supposed to be applied to the most proximal regions of the upper and the lower limbs. And we consider that we partially restrict the arterial inflow and fully restrict the venous flow. So there are specific results after this application, and the results are concentrating in improving performance. And lately, as physiotherapists and rehabilitators, we enjoy effects after resistance and no resistance training protocols. When we are talking about non-resistant protocols, we have to consider that there is a passive use of blood flow restriction training, and also there is a utilization of the method during aerobic exercises like cycling or walking types of training. So why this method is very popular? It's very popular. It started from the athlete fields, because competitive athletes need better performance. And indeed, we have solid evidence that skeletal muscles increases in terms of their strength in a range between 7 to 27%, and we have hypertrophy results between 3 to 7% in the same amount of time when we're comparing low load exercises with BFR to high load exercises without BFR. And lately, in the last 5 years, we have increased evidence showing that we can accomplish pain decrease in symptomatic population. And the show begins. We have seen a lot of studies, including new osteoarthritic patients or at-risk osteoarthritic patients. We have seen patellofemoral pain syndrome groups of people, post-operative knee arthroscopy from different pathologies, patients after anterior cruciate ligament reconstruction, low back pain patients. Yes, indeed, we have one study trying to compare the use of a training program with blood flow restriction in the lower leg after low back pain. And of course, we have increased evidence reports for the use of this method in older adults with sarcopenia and dynapenia. And all of this evidence suggests that we should use the method in order to improve our treatment outcomes. However, as you may realize, all these results are coming from the lower limb. So the research data for the upper limb is limited. This was my initial question: why not to use the method in the upper limb tendinopathy? So I have found only one good quality of evidence that suggests that the use of BFR with electrical stimulation compared to electrical stimulation alone in a group of patients with spinal cord injury using the method for 6 weeks can have a very good result in the cross-sectional area of the extensor carpi radialis brevis, around 70%. So this can be a very good start for using the method in patients in the upper limb. Multiple questions may arise about the use of the method in the clinical setting. So what will be the best equipment to use? Now we know that there are specific types. So we can start with the discussion between a sophisticated system, an automatic system, or a handheld manual blood pressure cuff. we have advantages and disadvantages in any method. Lately, there is a trend of using elastic wraps for athletes. However, there are issues about pressure, and as you may realize, the pressure matters because the evidence suggests that as much as we individualize our approach, the results become better. Of course, unpublished evidence, discussion with Mr. Korakakis, but don't say anything, suggests that the pressure matters and the pressure has to be high enough in order to provoke systems. Protocols are another area of debate. There are certain things that we know and certain things that we have to explore further. We know that we have to use specific repetitions, so most exercises have to be more than 75 reps for accomplishing better results. We have to consider that our treatment plan or our exercising protocols have to last more than 3 weeks and definitely up to 12 weeks in order to accomplish better outcomes. And as we rely on certain things that we know, I feel that further from what Mr. Papakostas indicated for the safety of the method, I have to discuss a little bit more the presence of adverse effects. So we have DOMs. Yes, every time we practice, we can experience this adverse effect. It might be a little bit more in blood flow restriction. According to reports, it is not more possible to experience this kind of reaction because the resistance that we use is lower than the higher levels of resistance that we use in normal training. The issue of rhabdomyolysis, yes, of course, we have to take it under consideration, but the reports include only one case of rhabdomyolysis under the use of blood flow restriction training. So the possibility, the risk to have rhabdomyolysis can be much more higher in all other training activities that we take in our lives. Probably the basic issue that we have to consider is the risk of deep vein thrombosis, and history is always the key issue under clinical environment. So history of the patient, family history, as Mr. Papakostas suggested, the occlusal pressure that we are going to use is a kind of precaution for us, and of course the resistance that we're going to use during the exercise. And many clinicians think, okay, am I going to use BFR and in which type of patients? Is it designed only for the youngest and the more active? According to the evidence, this can be extended to several group of people. So as you can see, Yasuda et al. 2015, they have used low resistance training for 6 weeks, and this did not result in significant risks for deep vein thrombosis, even if their group of patients was between 60 to 84 years old. Lastly, as far as my experience, the issue that you are going to face after BFR training is muscle soreness and numbness. Sometimes it happens because our nervous system becomes more irritated under pressure. That's why you have to keep in mind that the frequency has to be kept twice per week, and the load has to be less than 30% or around 30% of RM. And of course, if you are using sophisticated systems, you can use the deflate system, which means that the pressure is going to be deflated during the breaks. So what happens in upper limb applications? Now, I'm going to discuss a little bit further about my experiment in lateral elbow tendinopathy patients. So I have to make a concern here. This is unpublished data. It's not we have not concluded in anything, and that's why I have to be very cautiously present what we are doing. Lateral elbow tendinopathy patients with more than 3 weeks symptoms, we are measuring with the baseline, and we are randomizing our participants between 2 groups. One group uses usual exercises with BFR, and the other group uses usual exercises with placebo BFR. Yes, we can use placebo with BFR with pressure less than 20% in the calf, just simply being in the arm. So we're using 2 sessions per week for 6 weeks, and this is the first follow-up period. And then we're getting our final follow-up after 12 weeks in order to compare our outcomes. And what does our outcomes include? We are including pain-free grip strength measurements, pain between 0 to 10. They are filling a questionnaire which is very famous for tennis elbow pain, patient-rated tennis elbow evaluation score. We are using self-perceived improvement, and we are calculating. We are trying to use elbow flexors and extensors isometric strength. Finally, we have included diagnostic ultrasound imaging for measuring changes into the entities of the tendon around the elbow from the common extensor origin. So our program includes, our program of blood flow restriction training includes 4 sets of different exercises. We are keeping these 75 reps for each exercise, 30, 15, 15, and 15 reps with 30 seconds rest, 1 minute interval of rest between the exercises, and we are applying 40% of occlusion, arterial occlusion, and we are using 30% of 1 repetition maximum, and this has to be without pain for the patient. So we are using exercises with elbow flexors, elbow extensors. We're using the metronome. Basically, we have to consider timing and evolving. And as you can imagine, patients are under the use of their wrist flexors and their wrist extensors, and all this training program evolves during 4 phases. In the first phase, we're using simpler exercises with lower resistance, and after a few weeks, we are evolving their exercises to more difficult parts. As far as some of our results, so we have different things to discuss for our results. However, as you may see in this slide, most of our patients becomes better and better, and we are very happy for that, because either with BFR or with placebo BFR, we can help our patients indeed. But as you may see in the upper left, we have some critical increase in pain-free grip strength, which is the most important outcome measure that we use in tennis elbow patients. So we have considerable higher increase in pain-free grip strength compared to the placebo group. And of course, we have self-perceived improvement, much improved or totally improved in the BFR group, compared to much improved or little improved in the placebo group. But we have to be cautious because the results are not final, and the number of people are very few. Right now, we are only in the first follow-up period. So BFR training is a trend or a paradigm shift? Did it come to change things in our rehabilitation programs, or it's going to leave? I think it's going to stay because research is very promising. However, many areas have to be evaluated further. And I consider this topic as the space oddity, and we are in the start of this oddity, and I feel a little bit this kind of spaceman in this spaceship. You know who is the captain of this spaceship, of course, Vasilios Korakakis. I'm talking about you. You're coming next. So before leaving you, I have food for thought for yourself, because we have talked a lot about the mechanisms under the actions. So we're talking about pain reduction. Vasilis is going to give you a good insight about it, but there are mechanisms under muscle growth or muscle responses that Mr. Papakostas described. And we have very recently a research published, as you can see from the title, the acute effects of BFR on maximal strength and endurance performance of the upper limbs. So what they have done, they have included 12 elite athletes, and they have exposed them in 3 different situations. They have used bench press exercise, you know, bench press, and they have used 3 situations. One situation in 150% of occlusion pressure, compared to 100% of arterial pressure, yes, maximum occlusion pressure, compared to non-blood flow restriction situation. And they have measured 1 repetition maximum test and 3 sets of 60% of 1 RM until the point of ending the exercises totally break point. So the results show that the use of 150% occlusion pressure is much more significantly better compared to 100% and non-BFR. So there are several questions regarding this research. What are the short-term results? Can we have this kind of changes in 1 RM performance after only 1 situation of training? Yes, we can have it. And what are the mechanisms underneath this change? Is it the protein growth, the hypoxia effect? No, probably not. And we have to think, they have used a bench press exercise, and they have in muscles in the peripheral extremity, and they have measured an exercise which includes other muscles which are not occluded, like the pectoralis major muscle. So there are several questions raised for the method, and that's why I said that this kind of area, of training area, is yet to have a lot of things in our knowledge. So if I can do it, you can do it definitely. You have to at least try it out, and there are a lot of things to share in the near future about blood flow restriction training. Thanks a lot for your patience. Thanks a lot for your time. And I will sit back and enjoy Captain Vasilios Korakakis in this space travel.
Okay, thank you, Stefanos. It looks that you are quite fit to be part of Star Trek with as you said, Captain Korakakis. Vasilis is a well-known Greek physio working for many years now in Aspetar, in the mecca of sports orthopedics and sport rehabilitation. But he's definitely well known in his spine and sports physiotherapy rehabilitation area, and with all his work and his expertise and definitely his educational activities, especially in the OMT part of Greek community, Greek physio community. He managed, of course, to be trained in spine techniques in the mecca of spine physical therapy in New Zealand. So he also has this kind of approach, and he's back in the roots with his MSc in the University of Thessaly in Trikala, and as a master degree, and then finishing up in biomechanics in his PhD. So with no further ado, I will give the floor to Vasilis Korakakis, but I also need to call for questions at the end of Vasilis' presentation. So our friends from ADAP, Guy and Milos, will sum up, and we'll have some fruitful discussion later on. So Vasilis, please share the screen with us, and you can go on. Thank you.
Thank you, Manos, for the introduction. Thank you, Stefanos, for the title of the captain, though I don't feel that I'm a captain. Thanks for the invitation, the MADAP team, Guy and Milos. I'm really happy to present at this webinar, not because of the subject of my talk, but also that it's quite nice to enjoy a cup of tea with your sweatpants and presenting like being in a conference. So I'm going to talk about anterior knee pain and the applications of blood flow restriction. And I'm going to walk you through, first of all, the several criteria and key considerations that we use in physical therapy and general in sports medicine practice in order to decide the reason that we use each treatment modality and each treatment approach. First of all, we need to think about the basic science because behind the condition and the pathology itself. We need to individualize our treatment. We need to follow the evidence. And of course, we need to use our clinical reasoning, plus take into consideration the pain and the biopsychosocial approach whenever is needed. The best paper I've ever read in terms of training, the key principles of training and optimal loading, was written by three friends of mine, Phil Glasgow, Nicola Phillips, and Chris Blickley. And this describes the way that we apply exercise, or in other words, loading in rehabilitation. So we get a muscle injury, a knee injury, and name the injury, and then we apply exercises. That means mechanical load that stimulates the tissue. And through neural and cellular pathways, we manage through mechanical, metabolic, morphological, functional, and psychosocial mechanisms to lead to the optimal form and function of the tissue. However, what makes more sense to understand in terms of rehabilitation is what means mechanical load. And mechanical load has to do with a lot of variables, like the type of exercise, the volume, the direction, the intensity, duration, and frequency. And all these principles must be adjusted or better fine-tuned according to the needs of the patient. What we're going to discuss about all these variables, we can apply also in terms of blood flow restriction training. There is no difference because both types of training, exercise training with or without blood flow restriction, has these variables to be adjusted according to the individual. Let's talk about the pathology. Everybody before me describes what the blood flow restriction has been used so far. And the number of published trials the last couple of years is extremely high compared to the previous years. However, the baseline and the main thing that is in common in all these pathologies that we use blood flow restriction is that most of them are getting better by using modalities or training or loading that improves the strength, or the strength itself or the training itself decreases pain. So bottom line, all these pathologies have a common base, strength and pain. Before I go through and discuss the reasoning behind using blood flow restriction in anterior knee pain or in pain in general, I have seen several times in Facebook, Twitter, social media, Instagram, applications of blood flow restriction in conditions that it doesn't make sense. Blood flow restriction is not the holy grail of physiotherapy or exercise training or loading. Blood flow restriction has to be used through clinical reasoning whenever we judge that we can improve or make the patient better. And in order to understand this, I will give you an example in terms of a muscle injury. I saw in Instagram and in Twitter application of blood flow restriction in acute muscle injury. So what we know from the best journal so far in terms of impact factor, the New England Journal of Medicine, that if you delay the initiation of rehabilitation for a week, so acute muscle injuries of the lower limb started rehabilitation the second day post-injury compared to 9th day post-injury, resulted in a significant difference between the groups, that is 3 weeks. 1 week delay of rehabilitation in muscle injuries results in 3 weeks delayed recovery. And if you see here the numbers in terms of recovery, we're discussing about 50, 55 days or 70 days. And if you read the paper, you actually will understand that the protocol they use is not the best protocol ever. However, they use some loading. Even though by not applying the best treatment plan and strategies, you will have a significant difference if you do not start early the muscle rehabilitation. Thus, this does not make very clear to everybody that you need to start fast and do as much as you can in order to rehabilitate these patients. And I don't get the picture behind this to use blood flow restriction in a muscle injury. We know from research, and I'm just presenting you now research from our organization, from Aspetar, in football players with hamstring injuries, what we can conclude from these studies, if you do exercises, a muscle injury will be fine in a time frame of about 3 to 4 weeks. The same applies if you apply platelet-rich plasma injections to these patients. The median duration of return to sports was 25 days. Even if you do placebo, it's 27 days. And if you do exercises, it's also 25 days. So muscle rehabilitation in terms to return to sports takes around 3 weeks. And if you check big clubs in Europe, male professional football teams with muscle injuries, different muscle injuries, not only hamstrings, the usual time to return to sports is 3 weeks. And this is not only the evidence up to date, because 50 years ago, the first published paper for hamstring injuries in Australia in 1969, they said in order to return to play, it took 2 to 3 weeks. So if you get this point, you can understand whatever you do, how much the evidence are mounting. And if you use the best treatment ever, you need to respect the tissue biology. And you cannot make a player return to sports faster if you apply blood flow restriction or PMP injections or other factors, name it. The answer to the reason behind this, that you cannot treat a muscle injury, comes from basic science. This was a presentation I saw a few years ago in a conference in Copenhagen. And here you can see in the screen that satellite cells on the surface of a regenerating human muscle fiber. And this is a picture taken from a fiber 30 days post-injury. The muscle fibers themselves, while demonstrating a clear, mature striation pattern at this time point, they maintain some signs of ongoing regeneration. These signs include the presence of nestin positive striations and 3 desmin positive satellite cells that are also visible here. What's the result of this? The result of this is that 30 days post-injury, we have signs of ongoing regeneration in the muscle fiber. So whatever you do, you cannot force the nature. So this is my perspective in terms of the don'ts in blood flow restriction. Always use the evidence. And let's use some reasoning in terms of how we can use blood flow restriction. And I'm going to talk about knee pain or knee joint or knee pathology in general. There is 3 major ways that you can use the blood flow restriction. You can use blood flow restriction training with high loads or low loads, depends on the protocol. If you have an athlete and you don't want to increase the load, the training load, if he has an acute spike on the training load, or it's during athletic training and competition and in season. Or even if you want to reduce the muscle, the delayed onset muscle soreness by applying lower load. So there is some implications in terms of using the blood flow restriction in healthy individuals. Yes, you can sustain the muscle strength, you can sustain the endurance, you can improve the muscle size. And this is the latest systematic review published in Scandinavian Journals of Medicine and Science and Sports, 2020, showing no significant differences between traditional strength training and blood flow restriction strength training. So it means you can use blood flow restriction if you have healthy individuals and you need to adjust or manage the load. There is also other implications in the use of blood flow restriction. And here is two different types of clinical reasoning. Some of the physiotherapists, they use the straight way, that is, if I will improve your strength or muscle activation, eventually the pain will be decreased. And this is a clinical case that we see in most of the conditions that we treat in sports medicine or musculoskeletal physiotherapy. So according to this theory and reasoning, what we have to do, we have to activate the muscles, go through a program of traditional strengthening, and evaluate the results in terms of pain and improve of function. I'm not aware about a lot of studies evaluating this design, but this is the best study published by a group with a lead author, a lady, Gilles, and in the same group was Jill Cook, that everybody knows here from tendinopathies. What they did, they randomized patients with anterior knee pain and more specifically patellofemoral pain into two groups: traditional strength training by applying sham blood flow restriction, that is just inflate the calf in 10 millimeters and do nothing else. So with enough space between the calf and the skin of two fingers to go through. And the other group did blood flow restriction at 60% of complete occlusion by using 30% of 1 repetition maximum. What they did also, they modified the traditional training, the traditional strength training, by decreasing the range of motion of strengthening. This is not a normal process, but this is something they used in order to accommodate for the pain during the strengthening. Because as we know, you don't want pain during strengthening because pain has an inhibitory effect in the effect of strengthening. So in a decreased range of motion for leg press and leg extension, they performed this type of exercises, traditional strength training, high loads following the American Academy guidelines in terms of training, more than 65% of 1 repetition maximum. And they compare this to the blood flow restriction training with lower loads, 30% of 1 repetition maximum. The conclusion of this paper was that the blood flow restriction training produced greater reduction in pain with daily living. So we're going through a strengthening protocol and we get a result in terms of pain. So strengthening, yes, decreases pain. However, the most striking effect of this application was that the subgroup with painful resisted knee extension had larger improvements in quadriceps strength from the blood flow restriction application. What this means, it means, yes, you can go through blood flow restriction in terms of strengthening, and as your patient is getting stronger, you will decrease the pain. And this is one way of clinical reasoning. However, there is another way of clinical reasoning, and this is my field. I cannot say that I'm an expert, but through experimentation and hit and miss and fails and a lot of stuff, what we do in physical therapy, we actually evaluate something, we see an effect, and we try to understand the reasoning behind this. So what you can do, instead of going through strengthening to decrease pain, you can decrease pain first and work on strengthening afterwards. Is what we do by applying kinesio tape, McConnell tape, acupuncture, whatever you can imagine. So by using our reasoning and just clinical observation, we figure out by doing strengthening, by using blood flow restriction, we get an immediate effect in pain reduction. So we published a study in a cohort, non-controlled study. After this, we followed up with a study by using a control group. And finally, we evaluated the effect of blood flow restriction compared to sham BFR, placebo BFR, compared to normal low load resistance training. And I will walk you through these papers, and I will present you the reasoning, first of all, the results, and also the guidelines you can follow in order to use it in your clinical practice. As outcome measures, what we used, it was just clinical observation, functional testing, not questionnaires, nothing specific, nothing that has to take a lot of time because it was clinical study. 3 different tests, shallow and deep single leg squat and step down test. All of these tests loading a lot the knee. Most of them have an eccentric control, and you can be, disabled if you have anterior knee pain. So these were our outcome measures, 3 functional tests in terms of a numeric pain rating scale. The protocol that we used. In this study, all patients followed the same low load resistance training protocol. The only difference between the groups in the studies that I will present you was the addition of blood flow restriction or some blood flow restriction. All the patients performed 4 sets of open kinetic chain knee extensions in a slow pace as indicated by a metronome. That means 2 seconds the concentric and 2 seconds the eccentric phase. The first set was performed to maximum possible repetitions, so do not stop at 30 repetitions. And this was followed by 3 sets of 15 repetitions with 30 seconds rest in between the sets. The termination of the first set was indicated by first, failure to shadow the pace of the metronome, or second, failure to fully extend the knee joint. The cuff was placed at the same proximal part of the exercise limb, and we did not deflate the cuff during the sets of exercises. We used 80% of complete arterial occlusion, and this was quite difficult by using Doppler ultrasound to calculate it. It was not standardized. We had a few issues, but now the problem is solved with the MADAP equipment because the protocol that I'm discussing now, it's already inside this equipment, and you can use it by the click of one button. In terms of the sound blood flow restriction, where applicable in the studies that I will discuss further, we were placed the cuff with enough room for 2 fingers between the skin and the cuff. And we used low load resistance training that was less than 5 kilograms. So we use adjustable ankle weights in order to adjust the low load resistance training. Something that is missing from most of the randomized controlled trials or the trials in physiotherapy and sports medicine is the lack of a clear description of exercises and the rules and the reasoning that we follow during the application of the protocols. Why? Because in clinical practice, when you have a patient that is afraid, you modify your training load according to what the patient says. And sometimes the pain might lead you to change your training protocol according to the pain of the patient. So the pain will guide you. And we have this type of applications in several randomized controlled trials, but also in several theories behind physiotherapy and rehabilitation. You can find papers that use a modified pain monitoring approach. Let's say, for example, in adolescents, we should not use a pain more than 2 out of 10 during exercises because pain more than this is not acceptable in terms of the result of the exercise. You can see other studies in rotator cuff tendinopathy, for example, or Achilles tendinopathy that they say a pain 5 out of 10 is an acceptable level of pain during exercises. In our studies, we used as an acceptable pain level 4. So we used a modified pain monitoring approach that was dictated the loading to a maximum of 5 kilograms by using variable adjustable ankle weights, such that the patient reported a maximum of 4 out of 10 during familiarization. If the patient had more pain, we had to decrease the load. So as you know, recently significant attention has been thrown to blood flow restriction. We have a lot of studies involving low load resistance training combined with partial blood flow restriction in ACL, in Achilles tendinopathy, in other issues. But to our knowledge, there is limited evidence according to the immediate and short-term effect of blood flow restriction when combined with low load resistance training in terms of pain. So I will present you a couple of studies from our group. In the first study was a non-controlled study of 30 anterior knee pain individuals that were enrolled in the study with broad inclusion criteria. So we had post-op ACL reconstructed patients, which was around 30%, patellar tendinopathy patients, follow-up after meniscal repairs or removals, fat pad syndromes, patellofemoral pain, and general stuff. So everything included. It's not a perfect trial, but actually you will see from the result that is some interesting things that you can take and use in your clinical practice. As outcome measures, we use these 3 tests, as I told you. And when the low load resistance training was combined with blood flow restriction, in this study, we found a moderate effect size in terms of pain reduction in all the outcome measures. And as you can see in the graphs here, the pain was reduced immediately after application, and the 45 minutes evaluation of pain followed a standardized physiotherapy session was stayed at the low level. What this means, I can use blood flow restriction, decrease the pain, and load my patient without pain for 45 minutes, and the pain stays decreased. So this is another application of blood flow restriction. The effect size was low, 0.6, and I will explain later why. I believe that is the mixture and the lack of homogeneity in our inclusion criteria that developed this issue. In the second study that we published recently also, it was a 2-arm randomized controlled trial that we had a direct comparison of low load resistance training compared to low load resistance training with blood flow restriction. And we included a more homogeneous sample of anterior knee pain patients. So we excluded tendinopathies, we excluded issues that do not have an effect of pain like patellofemoral pain. So we included more patients with anterior knee pain resulting from post-op surgery, ACL reconstruction, and patellofemoral pain. The results, despite the lack of between group differences, the study indicated high reductions in terms of pain with large and very large effect sizes that were found only in the blood flow restriction group. There were no significant differences in the low load resistance training group. The most clinically relevant finding of the study was the presence of no responders to the BFR group, an effect not seen to the low load resistance training group. In easy words, what this means, if you do BFR, every patient will get a pain reduction. If you do exercises, some of the patients will get pain reduction, some patients will get no change, and some patients will get worse. This is a very important clinical point. In the third study that we ran, it was a 3-arm randomized controlled trial comparing blood flow restriction compared to exercises only, compared to some BFR plus exercises. The groups were small, so I will discuss these results, and you can interpret these results with caution. A graphical representation of the outcomes will help us understand the trends as well as the within-group differences and the effects. The vertical axis represents the pain in a numerical rating scale from 0 to 10, and the 3 evaluation time points are shown on the horizontal axis. What this means, 3 functional tests, pre-blood flow restriction or pre-exercises, immediately after, following by a physical therapy session and evaluating the pain afterwards after 45 minutes. The blue line in the graph signifies the blood flow restriction group. The red line signifies the low load resistance training group, and the orange line signifies the sham BFR group. A clear trend was found in favor of blood flow restriction training for shallow, deep, single leg squat, and step down test. And if we focus on the immediate direct effect of blood flow restriction, you will see a 70% absolute pain reduction for the blood flow restriction group, a 57% absolute pain reduction when we do deep single leg squat, and an absolute pain reduction of 63% in the blood flow restriction group during the step down test. The relative pain reduction compared to the rest of the groups was at best 50% compared to the 2 groups, placebo or exercise only. What this means, it means that you can get an effect by doing exercises, but the effect is not that big as by applying blood flow restriction as a pre-rehabilitation technique. In this study, and I will explain later more what means big pain reduction. In the shallow single leg squat, the effect sizes, and in order to translate the effect sizes, you have to use the pooled standard deviation. What this means, if you see here in the graph, the mean pain for the group that did BFR was about 4.5 out of 10. Following the application of BFR, the pain was decreased from 3.2 to 3.8 points in a numeric rating scale, resulting in a pain of 1 out of 10 as a mean, an effect not seen in the 2 other groups. Same pain reduction was found in deep single leg squat, and the same pain reduction was found for the step down test. Please note that the effect sizes immediately post BFR range from 1 to 1.44, huge effect sizes in studies regarding rehabilitation and physical therapy in general. Individual patient data for the functional tests were also analyzed for the clinical interpretation of the results. All participants' pain was decreased in the blood flow restriction group, as compared to the 25% of the sham BFR, the 50% of the low load resistance training group. Again, we didn't find any non-responders to all the tests in the blood flow restriction group. Finally, what can we take home from this presentation? Blood flow restriction led to clinically significant reduction of anterior knee pain immediately post-intervention. We found no non-responders in the BFR application by applying low load resistance training. Blood flow resistance training might be used to reduce anterior knee pain before rehabilitation or before strengthening. And as I showed you before, by using the data from one study that they use the step-down test, the test that we use in our studies also, by using kinesio tape, you reduce the pain less than 1 out of 10 in a visual analog scale. By using McConnell tape in patellofemoral pain, you decrease the pain 0.8 out of 10 in a visual analog scale. By using sham tape, you decrease 0.9 in a visual analog scale the pain. So what's the reason to use a taping, or what's the reason to use other types of treatment, pre-treatment, if I can use something so powerful and I can decrease the pain and load my patient afterwards? So finally, and this is my conclusive comment, blood flow restriction provides a window of opportunity for the clinicians for knee loading exercises which are typically otherwise associated with symptoms. And before I conclude my presentation, I would like to thank the company for the invitation and also invite everybody to a BJSM approved 2-day course that will be held in Greece in the 4th and 5th of December, organized by HOMT Diploma. And me and Stefanos will present everything about the clinical applications of blood flow restriction. Thank you.
So thank you, Vasilis. Please answer your screen, because the next step now is for our friends from ADAP, most probably Guy and Milos, to set up the discussion according to our participants' questions. I would like to thank you, both you and Stefanos, for giving us the opportunity to realize that in a clinical setting, there are a lot of things that we can move from the trend or from social media and what is going on to clinical reasoning, as you said, and evidence-based sports physical therapy and sports medicine and sports orthopedics. It is proven also in my mind that there are definitely very good clinicians out there who can combine clinical workload with research and education, and this is a great theater for us to show up that we are, although we're coming from a small country, but we can be in a way leaders in as you said, the clinical reasoning and helping patients getting better results. But I also strongly believe, since my first knowledge, let's say, and first getting in first contact with BFR, I strongly believe that there is a good way to help our patients by this. So I thank you again, and I take now the opportunity for the next maybe 10-15 minutes to go for some questions, if there are any. I also remind everybody that this session was already recorded, and I guess you will get some information from the MADAP training Facebook or website to reach again, and maybe to solve some of your questions regarding this technology. And I guess that everybody is open up, like Vasilis, Stefanos, and myself. We are open for any questions later on. So Guy, what is going on? Are there? Give us some insight and some information regarding the participants. I guess not only from Greece. Huh?
No. Thank you. Thank you for everybody who's watched the live. As you said, Dr. Papakostas, it was many people from England, from France, from Germany, from Portugal, and it was like an international one. So I think there are a few questions coming in. Let me tell you, so I've got two questions. So what is the effect on BFR training on isometrics? I don't know if you heard me, guys. You're on mute, so I cannot.
Yeah, we heard you, but I think that both Vasilis and Stefanos can give some answer to this.
I'm happy to answer this one. There is limited evidence in terms of the use of isometrics and the application of blood flow restriction. Actually, there is 2 studies evaluating the effect of isometrics during early rehabilitation following ACL reconstruction by showing conflicting results. One study showed a significant effect, one study showed no effect. So I'm not using isometrics as pre-rehabilitation in ACL patients. We use it for other reasons instead of using just isometrics. And I'm not a perfect person to give you the evidence in terms of what is going on with isometrics and BFR.
If I may say something, I have a limited experience, of course, being a sports orthopedic surgeon and not a guy who deals with the rehabilitation itself. But I do have a very good anecdotal, of course, and personal experience with the passive mode, with a passive mode of MADA Pro, which gives, I think I gave you a small clue with one video, but this comes into combination with what Vasilis described in terms of pain. And I do find this very, very, very helpful in painful situation after surgical procedures, whatever the surgical procedure would be. I will find maybe this is another area of research, and we can by having this passive mode, we can deal and we can measure up and see what's going on in terms of pain. But to give you my personal experience, as I stated before, with more than 20 patients in our practice back when I was in Greece, I can say that this works. And I don't know if it's a placebo effect. Definitely not in my opinion, but we need to set it up. But anyway, I cannot support the isometric, the effect on isometric strength myself. And I strongly believe also and I agree with Vasilis, but I think that the passive mode protocol is exceptionally good and safe for the patients to be applied just after surgical operations or even injuries.
Okay, I've got a second question. So what is the effect of BFR on aerobic and anaerobic trainings?
If I may say something, I know that there are some studies, let's say, trying to set up the effect, but I think it's only something that cannot be supported. The only way that can have some positive, let's say, effect is by increasing strength, muscle strength, which is I don't say not even a secondary mechanism, but in order to support something like this, there are a lot of parameters and factors that playing role. So I don't think that this is supported, or in my opinion, humble opinion, I don't think that this will be supported down the line.
Okay, I've got another question. So the protocol we will use in the muscle depend on the kind of predominant percentage of its fiber, slow or fast oxidative.
No, I don't think so, but I think that both our guests can give their opinion on this.
Yeah, I don't the specification in how much of an occlusion you will use in the fast and slow fibers. And I don't get the reasoning of doing fast or extremely fast exercising by using blood flow restriction. By occluding the flow and by using the muscle, you are just using hypoxia, and this has a secondary effect in terms of the muscle fibers. So the speed of the application might have a reasoning in order to use it, but the specification of the application in terms of muscle fiber type, I don't think there is a ground in blood flow restriction training for this. You cannot specify the muscle fibers that will be trained if you change the occlusion pressure. It's a guess because there is no studies like this, but based on physiology, I don't think there is something behind that.
Okay.
So
Yes,
can I have an input in this point?
Yeah.
So there are multiple questions about the type of BFR training that we can use in different situations, I suppose, and this is very normal. So as clinicians, our first reasoning comes from what patients we have to deal with. So if we're talking about aerobic and non-aerobic situation, aerobic exercises with BFR, we have to differentiate between what we have with evidence and what we can use in practice in order to find out some effects that are not published yet. For example, there is a strong research report for the use of BFR during walking or during cycling in order to improve muscle strength in older population, which is more difficult to get improvements if you have to use long-last training programs. So this can be a very useful idea for our practice. Older people using BFR training, 30% of occlusion or 30 to 70% occlusion on the lower limbs, and working for short of period of times and have improvements, comparable improvements to non-BFR training. Another issue is about isometric exercises or the use of fast type or slow type contractions. So are we talking about performance athletes, or are we talking about the situations like Vasilis described, the period before training, before treatment or after treatment? If we're talking about athletes, we can have a number of applications that can be experimental applications. So the trend, the basic knowledge relies on the mechanisms of muscle growth and hypoxia and reaction to these hormones. However, there is a new theories or developed theories that we can use the same applications in order to provoke muscles under pressure or provoke mechanisms of the body that we don't know yet. So if we're talking about athletes, it might work to use fast or slow contractions. If we're talking about patients, we have to consider heavily what will be the effect of this type of contractions and if they can be if they can change our clinical results. And as we have seen, the evidence so far suggests that we have to use slow type of contractions in order to decrease pain and improve other outcomes like disability reduction, etc. So this is my point of view on these questions.
Okay. There is here the good question. So there is two questions interesting. Sorry. So how many times after ACL surgery do we use BFR?
How much time is safe to use?
Yes, after ACL surgery.
You can start up with the passive mode as early as possible, and you can continue up to the point, in my opinion, up to the point that you work low load and you need to get the best possible result. So this means that definitely not necessarily when you are dealing with the on-field part of rehabilitation, but there is no contraindication to work as a training mode, not as a rehabilitation mode from that point on. So in my opinion, there are some applications that can be used in a different way, the whole period of the whole recovery and reaching up to the point of getting back into full activity.
Yes, that was a great question. So that person says, I had an experience of early ACL reconstruction by the time I used BFR. We have at the end increases of edema in the knee. Any idea why this happened?
I guess this is a personal experience, so it's something like an individualized. Maybe this patient is also a sweller, not necessarily the BFR is the cause of the swelling of the knee, but on the other hand, maybe even low load strengthening exercises can increase regardless of BFR or not. So it's a wild guess, but I think that this might be a case of a patient who most probably would have episodes of swelling, and this needs to be treated in a different way and maybe implement BFR later down the line. I don't know if Stefanos or Vasilis has a different approach on this.
I would like to add on this that you cannot be sure if this is an effect of the blood flow restriction or a result of an overload. Because overload, we might have it in our mind that might be, let's say, a lot of kilos, a lot of repetitions. However, following a surgery, and if the knee is sensitized and sensitive in general, even really low load might be a huge load for the knee, and then you get a reaction.
Okay. So are there any adverse effects regarding BFR training and overweight, obese patient? Is it safe for them to use?
I will share my personal experience here. And this is not evidence, it's just clinical experience.
Mm-hmm.
In obese or fat individuals, blood flow restriction does not seem to work in terms of pain reduction. Don't ask me to explain the reason, and this is just a clinical observation. Adverse events might happen to anybody. Most of them were described by Dr. Papakostas and by Stefanos, and the same applies in obese individuals, I guess.
Okay. I think it's about all for the question. I think for the people that want more questions, you can just drop them on the Facebook page, and we will manage to respond to you all. And I want personally to thank all the participants. So thank you guys for coming and then for giving us this beautiful speech. And thank for the participants all across the world that come to listen to this talk on BFR, this webinar. And we hope you enjoyed it. It will stay live on different pages and also in our pages. So do not hesitate if you have any question. And then thank you, everybody.
It was a pleasure.
Thank you. Thank you.
It was an honor for everybody. Thank you. Thank you very much. Thank you.
It was a pleasure. Enjoy your night, guys.
Thank you, guys.
Finish up your 5th cup of tea, please, Vasilis.
The same one that I'm recycling, you know?
Yeah, I know.
No alcohol there.
Not yet.
Okay, thank you,
Now
guys.
it's time.
Yes.
Thanks, guys.
Bye-bye.
Bye-bye.